it's easy to understand how a neurologist like myself, who prescribes pills to replenish the lack of dopamine, is just carrying water to the sea or beating a dead horse. You need a multidisciplinary approach to optimally support people with Parkinson's.
Welcome to Split Decision. In this episode, we explore Parkinson's disease with internationally renowned neurologist, Professor Bas Bloem from Radboud University Medical Center. Professor Bloem, acclaimed for his groundbreaking research, shares insights from his illustrious career, starting from his medical degree to his current role directing the Center of Expertise for Parkinson and Movement Disorders. We explore his pioneering approach to integrating clinical practice with cutting-edge academic research. He helps us better understand what exactly is Parkinson's disease and tells us more about the importance of environmental factors, patient-centered care, and the role of even non-medical professionals in its treatment. The episode also highlights his innovative ParkinsonNet initiative, a novel network fostering vital connections between individuals with the disease and healthcare providers. Through his expertise, we gain real valuable insights into the challenges and future prospects of managing and researching Parkinson's disease, making this episode perfect for anyone interested in the cutting edge of neurological care and research across disciplines.
In today's episode, we are really interested in Parkinson's disease. We're interested in all of the decisions that go around the disease, treating it, understanding it. Before we go into that, can you tell us a bit about your decision-making, specifically your decision to study and become an expert in Parkinson's disease?
Well, I can answer it in a very generic fashion. So I'm an intuitive decision maker. I listen to my belly and I make decisions quick, and I find rational arguments to support my choice later. I know that some people make their decisions after very careful deliberation, weighing all the pros and cons, but I'm a very intuitive person. For example, when I hire new personnel, when I decide whether or not I go for a grant or whether I see an opportunity, it's usually a split-second decision. And of course, I'm enough of a scientist to then work it out in a more meticulous fashion, but I make quick decisions. My decision, an example perhaps, is that I chose to become a neurologist because my mother had a neurological condition, multiple sclerosis. And as a 3-year-old, I had already decided, again, probably an emotional decision, to cure my mother and to become a neurologist. And I went into medical school with that perspective. And then in the 3rd year of my education, I wanted to go to the United States to boost my career. And it just happened so to be the case that there was an American professor who studied Parkinson's disease at the Leiden University Medical Center where I was trained. And so my boss introduced me to him and I switched to Parkinson's disease. And I've now been asked to give leadership courses. And I always tell people, you must have a dream and you have to stay close to your dream. But at the same time, you shouldn't be too anxious to adjust your dream just a little bit. So I didn't change from neurology to archaeology, but I did change from multiple sclerosis to Parkinson's when the opportunity arose. And that was, again, a quick decision, although I have to say that Parkinson's really grasped my heart. I've seen these people. I think it's a fascinating disease. I think the people themselves are wonderful, and I'm impressed with their resilience. It's a topic that's very close to my heart. We can talk about that later if you're interested. Very interested in how people bounce back from, having this horrible diagnosis. And so I've dedicated my life to this condition now.
Right, and we will indeed get into the more specifics of the disease itself. And there are some really inspiring stories that come from your patients that really shed light on the power of people, of patients, and having to deal with this disease. Before we get into that, there's also another interesting aspect to what you do, and that is you are a clinician. You see patients of a wide range, even as young as 13, but you are also very actively involved in research. So you are really involved in working towards understanding and disseminating this knowledge. So why do you find that to be particularly important to both work in the practice, but also in the study of the disease?
Well, I think the great joy in life is in the interaction between the two. You can say that seeing patients is more of an immediate reward. If you are my patient, I give you an advice. I can see maybe the immediate smile in your face if I give you advice. There will be a tangible effect within 2 or 3 weeks. Whereas studies we're doing to find new biomarkers for Parkinson's, new treatments to slow the progression may take decades for them to be successful. So the time span of reward is different. And it's interesting, dopamine is involved in reward. It's also the neurotransmitter lacking in Parkinson's disease. I like the interaction because I can motivate the patients tell me which questions I need to address in my research. So in many ways, the individual, we shouldn't use the word patient, by the way. I hate the word patient. So these individuals or persons, I should say, living with this disease are my muse. They tell me what I should investigate. They then are participants in that very same research, and not just as objects, but literally as co-workers. So we engage individuals living with Parkinson's in the design of the studies, in the fundraising, in the interpretation of the findings, in the writing of the papers. I'm increasingly putting patients, individuals on the author list. And then ultimately you have your result. And my type of research tends to be more applied. And then you feed it back into your examination room to the same patients that originally motivated your research. So as an example, a quick one, we just recently showed that aerobic exercise 3 times a week leads to adaptive plasticity in the brain, sprouting of new connections between the diseased basal ganglia and the healthy cortex. We stopped atrophy from happening, and it led to clinical stabilization of symptoms. I used that finding, which we published 4 or 5 weeks ago in Annals of Neurology, already in every single session with my patients to motivate them to engage in regular exercise. So the question started with patients and said, do I need to exercise? We run the study, we make the findings, and I feed it back. So that circle is something that gives me great joy in life.
Right, absolutely. So they're really connected. And this is it's a core aspect of what our Center for Decision Science is aiming to do, is to make that connection, to make that circle. There are a lot of things that you touched upon that are really interesting, including patients getting themselves involved. Before we jump ahead, let's step back a little bit, maybe to the listeners that don't have a very clear idea. Maybe they've seen, for example, a celebrity like Michael J. Fox, or, for example, the Pope. They have an idea of what Parkinson's disease is. Can you explain what is our current understanding of what this disease is?
Yeah, so it's true that Parkinson's is a very visible, recognizable condition. James Parkinson described the disease originally based upon a number of individuals whom he merely observed walking in the streets of London. It's a disease that's hard to miss. Either one of us could have diabetes and we wouldn't know. If you had Parkinson's, I would know, I would see it. At the same time, what we see on the outside is the tip of the iceberg. Bill Langston, the very same neurologist who was in Leiden in 1989 and motivated me to go to the United States, has a famous paper with an iceberg. 10% is the tip of the iceberg, and that's the motor symptoms, the slowness, the tremor, the rigidity, the changes in gait and balance. The piece of the iceberg that's below the surface, the dementia, depression, pain, autonomic dysfunction, urinary incontinence, constipation, sexual issues, sleep issues, It's a horrible disease. And these non-motor symptoms are much less visible. Patients themselves refer to it as our invisible symptoms, are deleterious, common, and difficult to treat. So it's a complex syndrome, if you will. There are multiple causes. I think we should not elaborate too much about the etiology here, but people who follow my work on social media, on television and radio know that I'm an ambassador against the toxic role of pesticides in causing Parkinson's. But there are multiple environmental issues related to Parkinson's. At the brain level, we know that on the one hand, a key area of the brain is the substantia nigra, the dopamine producing cells in the substantia nigra which degenerate. But again, that's a simplification. The latest insight is that Parkinson's, for many individuals, starts in the gut. It kills off neurons in the gut, then proceeds by following the vagal nerve all the way until it reaches the brain stem. There it may cause a REM sleep behavior disorder, acting out your dreams. And then like a bath that fills up with water, the pathology goes higher and higher until it reaches the upper brain stem, which is the substantia nigra. And it's only then that we make the diagnosis. But Parkinson's is probably already at play for at least 7 to 10 years, if not 20 to 30 years. And ultimately, the pathology reaches the brain's cortex. So if you look at end-stage Parkinson's with staining for alpha-synuclein, which is the pathological protein accumulating in the brain, the whole brain is on fire. So ultimately, most of the brain gets destructed, which explains why in the later stages, people do become demented and have all sorts of complex issues in the later phases of the disease. So a very complex phenotype, a complex underlying brain pathology.
Indeed, it is a very complex disease. It's incredibly complex. And what you mentioned previously, and I think we should spend a little bit of time on it, is this idea or the concept of the environment affecting us. So that might not necessarily have something to do with decision making, but in fact it does. For example, the foods we choose to eat. Could you elaborate a little bit more on the role of the environment in this disease?
No, I think this is decision making. It affects our choices as individuals, but this involves decision making by politicians at the European level to ban toxic pesticides, to have a push towards healthier alternatives. So James Parkinson, as I said earlier, described the disease in 1817 in London. What is interesting is that the disease was distinctly very rare indeed, prior to 1817. Now, Parkinson's is an age-related disease, so the older you get, the higher the risk. And obviously people didn't grow as old in the early 19th century, but some people did grow old. Parkinson's does affect people in their 30s and 40s. So, and it's a disease that's hard to be missed. And people were good at making very careful, judicious descriptions of clinical phenotypes. So if Parkinson's had existed, if only as a rare condition, it should have appeared on paintings, in books, in poetry, and it didn't. So it was a new disease, and the disease is now beginning to explode. This is not just because we're growing older, because even after correction for the aging effect, Parkinson's continues to accelerate. So there's more than aging alone. And by the way, I don't think that aging itself is a cause of Parkinson's. Aging means you've had more time to be exposed to toxic chemicals in our environment. I mentioned air pollution, and a number of studies, including recent work from Korea, is confirming that air pollution is related to Parkinson's. But we are specifically concerned about pesticides. Pesticides have been introduced in the world after the Second World War to feed a fast-growing world population. And what we see is that there is a very tight correlation between the incidence, the regional incidence of Parkinson's and the use of pesticides and the presence of agriculture. If Parkinson's was unrelated to the environment, and you would draw a map of the number of people per region, you would expect this to be like a porridge, evenly distributed. But instead, in France, in the United States, in Canada, it looks like there are pockets clusters of Parkinson's, and these overlap very tightly with the use of pesticides in agriculture. And there's even a dose-response relationship. Now, that could be an association and not necessarily a causal relationship, but when you feed these pesticides to rodents, mice, and rats, it kills off the very same substantia nigra, causes Parkinson's symptoms in these animals. And finally, there was a story in the early 1980s in California, and this will come back to the same Bill Langston that I mentioned earlier. Bill Langston, the guy who took me to California, identified in California 7 young drug addicts who had injected themselves with a self-synthesized heroin analog, a designer drug, a slightly modified heroin variant manufactured by what they called kitchen chemists. And after self-injection intravenously, they subacutely, almost overnight, developed irreversible end-stage Parkinson's disease. That chemical is called MPTP. It's now the most widely used toxin to cause Parkinson's in animals to study the disease. MPTP looks almost identical to paraquat, a well-known and widely used pesticide in the world. And both paraquat and MPTP kill neurons in the substantia nigra by inhibiting the mitochondria, the cell's breathing system. And many other pesticides like rotenone do the exact same thing. So the epidemiological work showing a high risk in farmers, showing a high risk in people living in the vicinity of agricultural lands, the rodent work and the MPTP story, to my mind, provide compelling and converging evidence that Parkinson's is, to my mind, largely a man-made disease. We're doing this to ourselves, and that means it's also a preventable condition. And just a quick final word, if I may. There is also a genetic component to Parkinson's. We know that there are some odd 8 genes which typically cause young onset Parkinson's disease. You mentioned the age of 13. One of my youngest patients is 13, but she has a genetic cause for her Parkinson's. But the latest work in the last, say, 3-4 years is now beginning to show that these same genes interact with pesticides. So if you introduce that genetic mutation in a mouse and you expose the mouse to the pesticides, you double the risk of them developing and the severity of their Parkinsonian signs. So this, to my mind, is very disconcerting. And, it means that we need to take rapid action to create a healthier environment.
Absolutely. And what we'll perhaps speak about in a little bit is the role that other professions outside of the medical field could potentially have in understanding and potentially treating Parkinson's disease. Before we get into that, let's go to the individuals, not the patients, like you said, the individuals that have to live with Parkinson's disease. So it was really fascinating. 2 years ago, you published a paper, an article in the Lancet, in which you called for the management of Parkinson's disease to be integrated and patient-centered. So for those who may not know what exactly that means, can you unpack that a little bit?
Sure. So given this complexity of the phenotype with a range of motor symptoms and a wide range of non-motor symptoms, given the complexity of the changes in the brain, it's easy to understand how a neurologist like myself, who prescribes pills to replenish the lack of dopamine, is just carrying water to the sea or beating a dead horse. You need a multidisciplinary approach to optimally support people with Parkinson's. And a multidisciplinary approach means a team that includes not just a doctor, but a neurologist, a nurse, a physiotherapist, an occupational therapist, a dietitian, a social worker. And in our paper in the Lancet, and if people are interested, they should see it. The star figure is a universe where the individual with the disease is depicted as the sun at the heart of the universe. We purposely did this to say there are no stars in the team. Some doctors still think they are gods and stars in the team. I don't think any of the professionals is a star, but the patient is the sun at the heart, and all these professional disciplines were orbiting around the individual living with the disease. Some professions are always involved, like the GP and the neurologist and the nurse. A second layer or circle consisted of physiotherapists that are often involved, or maybe social workers. And the outer layer was the less usual suspects. The gastroenterologist, we talked about the gut, the dentist, palliative care, and the list goes on. And there are over 30 professions that can potentially support people with Parkinson's. Now, that's not to say all of them need to be involved in every individual at all time. And now it comes to decision making and to personalized medicine. You sit down with the individual and the family, you look at their unique Parkinson's, their unique priorities, and that is really shared decision making. And then you take from this whole range of disciplines the best professionals to support that particular individual at that point in time. And that's truly shared decision making. But that means making the individual knowledgeable, getting rid of the inequalities in knowledge. And I always say individuals with the disease and the professionals are equal. We're not identical. I have medical knowledge, I have insights, but they know the priorities and they know what is needed most. And together, as a team, we make the joint decision.
Right.
So that's interesting.
So it is indeed a team effort. So it's really interesting, and it perhaps makes us think, for example, of us as individuals. So if we are an individual, we know the experience of what it might be to have a disease. We know what it affects us in our day-to-day life, but there might be some gaps in that knowledge in working in this team. For example, if we were to work with someone that's out of our profession, there is that gap of knowledge. So have you encountered that? Do you find that patients or individuals with Parkinson's disease find that difficult? Is there a way that they can make that bridge or that gap a little smaller?
So one of the challenges in healthcare in general is that I've likened it to homeopathy. We tend to do a little bit of everything. And oftentimes physicians like a diverse menu when they have their clinics with many different patients or many different types of disorders. But if you have Parkinson's disease, what you deserve, literally, is somebody who is committed to your condition, who knows all the guidelines, who is aware of what other professions can do, and who treats a high caseload. So what we've developed, and this is a proud Nijmegen Radboud product, is ParkinsonNet. ParkinsonNet is a nationwide network where out of these 30 disciplines, we've now trained 15, and we're growing still. And instead of letting every physiotherapist treat 1 or 2 patients, we selected 1,000 therapists who now treat up to 20 or sometimes 90 patients in their clinic. So we make these professionals better by training them according to the latest guidelines. We provide online education year in, year out, but by treating many individuals, you become better and better and better. And that is called ParkinsonNet, focused expertise among a limited number of professionals. And the individuals with the disease decide whether and to whom they go. So there's a healthcare finder on the internet to which we refer the individuals, and they can click on the healthcare finder. In Google Maps, it will show you where these professionals are working. You can review their faces, the photos, their track record, and they decide, talking about decision making, whether they go, to whom they go, and when they go. Right. This is empowering patients.
Absolutely. So there is an aspect to which individuals should feel empowered in this decision-making process. One thing that's perhaps, and it's what we've noticed through several of our episodes, is the idea of context. So for example, if you're an individual with the disease in the Netherlands, it might be quite different to living with the disease, for example, in my home country of South Africa. Do you have any insight into how this differs between countries? Is there a difference?
Yes, I think so. In our paper in The Lancet, which you mentioned, we actually do mention an example from South Africa, where in certain parts of your mother country, Parkinson's disease is seen as a curse of God. So here we are in the Western world with modern integrated care models, whereas in other parts of the world, people are punished for their disease, which I think is incredible. But even closer to home, my clinic consists of, I would say, 95% Caucasians, predominantly men, which is not a real reflection of the real world of Parkinson's. So in 2022, in what I think is one of the better centers in the world, we are doing a poor job at reaching out to underserved populations. We're doing a poor job in delivering good care to women. Women receive worse care than men in 2022 in the Netherlands. We're doing a number of PhD trajectories to better understand this and to improve our services. But we're not doing a great job at helping women, let alone people from non-Western origin, where cultural differences, religious perceptions, dietary differences, genetic differences between cultures can really affect how Parkinson's manifests itself, but particular how the disease behavior is colored. And we are about to start a new project on diversity, and that is one of the star projects that's very close to my heart.
Right, absolutely. So much needed research in this area. So
yeah.
Moving now from the individual now to what you're speaking about, where you get more professions, you get more multidisciplinary teams involved. And it was really interesting. I really love, there was a paper you released about 5 years ago where you said traditionally there were about maybe 15 professions, and then there was the new kids on the block, like that 90s band, where it expanded that. So there are potentially, like you said earlier, other fields, dentistry, that need to also get involved. However, there's probably some challenges with trying to get everyone on the same kind of level. Have you experienced that? How do you overcome the challenges of working with multidisciplinary teams?
So our ParkinsonNet approach is to a large extent an answer to that question. When we train the participating professionals, it's typically a 3-day course. The first day is unique or is identical, regardless of whether you're a dentist, a physiotherapist, or a nurse. So that's what is Parkinson's disease as a condition, what does it look like, etiology, etc. The second day is dentist-specific training or physiotherapy-specific training. So they split up in multiple rooms and they do their own thing. And then the third day, we bring them together and then they start to look at case histories from a multidisciplinary perspective and learn how to collaborate. Our national annual conferences always have an extremely multidisciplinary character, where our keynote speakers and our keynote plenary lectures always address Parkinson's from a very multidisciplinary perspective. So we do both. Monodisciplinary training, making you better in your job, but also teamwork.
And what have you found to be the positives from that, as opposed to what it traditionally was? Is there a particular insight that came from having that, or a particular example that you found was really successful, having that bigger team?
Yes, I think people like to collaborate. So the reason collaboration is so poor in the Netherlands and even worse elsewhere in the world is people find it difficult to find other people equally interested in treating people with Parkinson's in this case. So I've often said the yellow pages of Parkinson's don't exist. But thanks to our web-based healthcare finder and our national ParkinsonNet, and the fact that we have brought the 3,500 people that we have trained together in a community, a Facebook-like community, means that it is now easier to find other people from other disciplines in your region that share the same passion and interest. And people like to collaborate. And as part of our training, and we've published about this, we have now shown that following the training, people now have an understanding of what the other discipline is doing and what they can contribute. So if you are a physiotherapist and you treat, for example, a walking problem, and the patient continues to fall because maybe the light in the house is poor or there's loose rugs on the floor, if you now know that an occupational therapist can reduce domestic hazards, this is a simple example, and you know a ParkinsonNet occupational therapist whom you can engage, you can work as a team and collectively address the issue of falls, which by definition requires a team approach. But in the earlier days, either you didn't know what the other discipline was doing, or you had a hunch, but you had no idea where to find a good one.
Right. And again, you keep mentioning the word team. So at the center of this, and a key player in this, is the individual themselves. It's also interesting to think about this. For example, if you hear about this and you're not in the medical profession, and you might think, well, you have these 30 odd disciplines, they are responsible and will be working towards treating Parkinson's. But you could potentially also think about, for example, people in technology, in AI, how they could get involved in creating real technological advances that help individuals with Parkinson's disease. Maybe even going further, individuals in environmental policy. If you're in policy making, you also have a role to play. Could you tell us a little bit more about the role of those that are not in the medical profession in treating Parkinson's disease?
Yeah, no, you're absolutely right. So if you think in terms of team approaches, it extends beyond the traditional medical world. And a lot of my research, in fact, an increasing proportion, is done in public-private partnerships. And I think if the conditions are right, if you are transparent about funding streams and interests and IP, etc., I think there's a lot of merit in public-private partnerships. And so we benefit from the knowledge, for example, within Verily Life Sciences, sister company of Google, with whom we've developed remote technology to measure people with Parkinson's in their own homes. We had a paper accepted this very week using their smartwatch, which is, I always call it the Rolls Royce among the smartwatches, which we've used to measure people in their own homes. And lo and behold, people at home show a fluctuating performance, which is typical of Parkinson's. So their scores are in a certain bandwidth. If you compare that to the score in the hospital, it's often outside the 99th percentile of their scores at home. In other words, what we see in the hospital is a completely wrong and biased perspective of how people perform in their own living environment. And this insight came through partnership with industry. But I partner with the CTBG, for example, which is the Dutch regulatory agency that allows pesticides onto the market in my attempts to create a healthier environment. I work with the Ministry of Health, VWS, in developing new funding mechanisms that promote collaboration instead of hampering collaboration. And the list of parties outside the medical world is growing fast. Medicine is not an island. Medicine is an integral part of society. And by working with professionals outside maybe one more example, if I may. We just obtained a large grant from the Austrian government to study art. Art as a medical intervention, art as a diagnostic tool. And I think this is wholly exciting. So I now work with people from the world of arts to improve the world of medicine. Two seemingly distinct worlds, which are actually much closer intertwined than you would ever think. And for those of you interested, Rui Arajo completed his PhD thesis on Monday, March 7th, with honors, with distinction. So he's my proud academic son. And his thesis was about the art of clinical neurology, drawing parallels between art and medicine. So I can go on and on. You know, I work with historians. We published a work with an historian about whether Parkinson's existed in earlier days and whether the phenotype has changed over the years. So this historian helped us to write that paper, and it gives so much pleasure to work with people who are much more knowledgeable than you in a subspecialty, but that can fortify your overall effort.
Absolutely. And again, this is really a core effort of our Center for Decision Science, where you are an expert in what might seem completely different field, but there are a lot of connections and a lot of ways that we can all benefit. To go to my penultimate question, I would just like to get a quick summary. I usually ask people for their top tips, but here I would like to get your advice, a few tips that you would have for individuals with Parkinson's disease in terms of their input, their role in their decision-making, their medical decision-making. Can you highlight a few things that you think they should be doing?
Yes, so I'm now addressing the individuals living with the disease, right? So first of all, get rid of the idea that there is a hierarchical relationship with the medical world. You are part of the team. Again, you're not identical, but you're equal. If anybody is the senior in the team, it's you, and definitely not the professional. At the same time, we all have our unique roles. So giving the right to co-decide to patients doesn't mean that they can demand certain things. So patients may say, I want deep brain surgery, but there can be medical reasons to deny that request. So it's shared decision making. Make yourself knowledgeable. Educate yourself, because that facilitates discussions with the medical team. So for example, one of the initiatives that I like most in my team is Parkinson TV. It's our web-based television program, which we broadcast every month. A panel of patients decides about the topics. There's always an individual. It's a talk show setting. We've done over 70 episodes around issues like work, sexuality, dietary issues, how to exercise. Review those episodes, become a member of the Dutch Parkinson Patient Association, the Parkinson Vereniging, and make yourself knowledgeable. I think those would be very important advices. And also, don't make yourself dependent on the medical team. The greatest joy that people with Parkinson's can do to themselves is to start exercising and have a healthy diet. So regular exercise is so critical. So don't wait for the doctor to provide you pills. Yes, it's an important cornerstone of the treatment, but exercise and lifestyle is important. Avoiding stress or resorting to stress alleviating treatments like yoga or mindfulness is crucial. A Mediterranean diet, a diet rich in fibers and a lot of fluids to keep your bowels moving is critical. So self-management, making yourself knowledgeable, and making decisions together with the team is a key advice.
Absolutely.
And keep hope. Keep hope.
Right. And some of that advice could also then, we could see, be applied to those that are in the medical profession, or for example, like we were talking about, those that might not be in the field, but who might have work that could impact. So again, seeing people as a team effort and
Yes.
No hierarchy. To end our conversation, I want to just stop at that last point that you said, which is about hope and optimism, which one might think is a bit strange to think about when you're thinking about something as complex and as terrible a disease as it might be. But you have often advocated that there is room for hope, there is room for optimism. Can you just explain that a little bit?
There's two things I'd like to say. So one is, I genuinely think that Parkinson's disease today is a different situation compared to, say, 10 and definitely 20 years ago. Our insights into what matters to people, the availability of multidisciplinary care, the potential arrival of the first disease-modifying treatments, the advent of deep brain surgery to treat Parkinson's with brain surgery, means that we can provide symptomatic relief to a much better extent than, say, 10, 20 years ago. People can have hope that within my lifetime, we will see the arrival of the first disease-modifying treatments that may slow down the progression of Parkinson's. The advocacy to get rid of pesticides and to create a healthier environment is fully alive, and I hope that we will soon be able to create fewer toxicity in our environment. But finally, to just conclude, we published a paper, again, just last week, which is one of my more special papers. I've published a lot, as you may know, but one of my more special papers just came out last week, and it was called The Silver Linings of Parkinson's Disease. And it touches directly upon your question. One of my patients asked me the question, is there an upside to having Parkinson's disease? And my immediate response was no, of course there isn't. You never asked for this disease. It's a debilitating disease. And clearly everybody wants a cure tomorrow or today. But I decided to pose that question on social media on his behalf. And we received a lot of responses that fell into three groups. There were one or two individuals who said, how do you dare to ask this question? And I said to these people, I apologize for any confusion I may have caused, but this is a fellow patient who asked the question. I didn't ask it, it was a fellow patient. And we're trying to understand this because we want to see if there is room for new targets to help you. And then these people understood. And there was a small group that said, I really can't see any benefits. It's just horrible to have this disease, and I understand. But there was a large group that said, I am now leading an active lifestyle. I exercise more. I eat better. I quit smoking. I've become an ambassador for Parkinson's. My relationships have improved. I've reduced my workload and I travel more. And this is not to say that people should be grateful to have Parkinson's. We need a cure. We need to help these people. But addressing the issue of silver linings opens up new avenues to discuss coping, resilience with your patients in the personal contact with that individual. The issue of a silver lining is a pitch dark cloud. That's Parkinson's disease. But with a thin silver lining is the upside. And realizing that there is this thin silver lining is now what I discuss in my clinics. And I find it very helpful as a new way, as part of this complex multidisciplinary approach to support people in a personalized manner.
Absolutely. And I think that's a very good way for us to end our conversation, to just keep that in mind, that there is, like it has differed from how it looked 10 years ago, there is the opportunity for it to look different 10 years from now if we all work together.
Yes, exactly.
Right. So thank you so much, Professor Bloem. It has been such a pleasure. I would recommend that those that are listening that want to know more, Professor Bloem has a very active social media account where you can hear and see all of his latest insights, Instagram, Facebook, LinkedIn, and Twitter. Is there any other resource that you would point them towards?
Yes, there is Parkinson TV. Which people may find interesting to review one or two of the episodes. You can review them offline under missed episodes. I've done a teaching course for the University of the Netherlands that has received close to 1 million views. It's been exceptionally well received, so people might enjoy seeing that. And my older TEDx lecture called From God to Guide is still a classic. It's already more than 10 years old, but I still think it's very accurate today. So those are other little things that people might be interested in.
And I will provide links to all of those. And the University of Netherlands lecture has English subtitles, so it is really accessible for everyone. So once again, thank you so much for joining us today, Professor Bloem.
You're welcome, Sarah, and thank you for this very nice and entertaining interview.